Hello viewers, today I am going to demonstrate you or discuss an interesting case which I think will be extremely useful for an orthopedic surgeon who is just beginning up the career, because this injury is quite frequently missed and it involves the medial epicondyle fracture. So I am going to show you the patient first, and then we are going to discuss the x-rays, and hopefully by end of it you should be able to diagnose this condition so that you don't miss it, and every time you should have a good outcome of your patient. So we have this 13-year-old boy which was play fighting with his friends and sustained injury to the elbow, which was unfortunately treated by a local quack, and he put the patient in some form of plaster and some massage, and he's presenting to us after a month with pain and inability to move the left shoulder, left elbow. So if you look the left hand, the left elbow, he can extend and hyperextend. Here, this is the position. So if I try to move it, this is the ROM. So there is hardly any range of motion. So this is stuck in around 90 degree of flexion. So supination is full, pronation is full. However, flexion is extremely painful and extension is also painful. So this elbow is essentially locked. You cannot move it. It could be due to stiffness, or it could be due to a pathology that I am going to discuss you today. So we have x-rayed his elbow, and I am going to show you what it shows. So this is this boy's AP x-ray. Now if you look at AP x-ray, I give you a few seconds to see what you see and see if you can spot any abnormality, and I would like you to be able to make this diagnosis at least, or suspect at least, by purely looking at the AP. In lateral it becomes obvious, but only if you are suspicious about this injury. If you don't suspect, then it will be very difficult to diagnose. So as somebody has said, what mind doesn't know, eyes can never see. So if you look at this AP, this is a 12-year-old gentleman, 13-year-old gentleman. If you see here, you should have a medial epicondyle ossification center, which is missing here. You can see this lateral condyle, you can see this trochlea, but this is missing. So once you see this missing, it must have gone somewhere. So if you're not able to look on the AP, and if your medial epicondyle is missing on an AP, this is a giveaway that medial epicondyle is injured and it is gone probably into the joint, and that is why, or at least behind, if not into the joint, then you should think that this is a medial epicondyle avulsion which is incarcerated. Now if you move on to the lateral joint x-rays of the same gentleman, if you can see, if you see this shadow here, this is where, this is what the medial epicondyle is. It is right into the joint, and hence this child has got no flexion and extension, because this joint is effectively locked due to medial epicondyle incarcerated. Now if you look at the joint line, if you see from here to here, and if you see from here to here, if I see if I can zoom it even more, Shant, keep it there. If I zoom it more, and if I try to show you, distance from there to there is very less, distance from there to there is more. So this means this joint is not congruently reduced. So this is another giveaway. So there is some incongruence of the joint, where the anterior joint line is narrow and posterior joint line is widened due to this foreign object, or the medial epicondyle stuck in. So once you take this AP and lateral in combination, then this is extremely easy to make this diagnosis. So if we zoom out again, Prashant, and if you see on AP, so in AP, missing medial epicondyle, and lateral medial epicondyle being stuck here is a giveaway of incarcerated medial epicondyle. So if you see this boy's hand, you can see this wasting here, and if you can see proximally here, there is also wasting of the flexor muscle compartment if you compare it with the other side. There is also, you can see clawing. If you're asking him to get his fingers straight, he is unable to do so, and you can see clawing of these two fingers. And this is quite classical, because this displaced medial epicondyle fragment can compress the ulnar nerve and can give you ulnar nerve symptoms. So appropriate examination of ulnar nerve is important, and its documentation is also important. So this is what you see clinically and what you see radiographically if you want to diagnose an incarcerated medial epicondyle fracture. So viewers, this was a demonstration of clinical finding as well as radiological finding of an incarcerated medial epicondyle fracture. Now, this fracture can be missed even by an experienced orthopedic surgeon if you don't look at the patient or the radiographs clinically, because we see adult patients quite commonly. Pediatric patients, you have to know at what age the different physes they appear or close, and this can be a usual giveaway. So on AP, if you see missing medial epicondyle, then you must try to see it on a lateral, and I'm sure you will find it within the joint every single time when the fragment is missing on an AP view. Also clinically look for ulnar nerve symptoms, and the giveaway will be the elbow will be almost locked. There will be hardly any flexion and extension because of the incarcerated fragment. So I hope you find this video useful, and I hope this will help you in your clinical practice, and you will not miss this serious injury, because if it missed, can be catastrophic for both patient as well as treating clinician. So please like this video, please do subscribe and share our channel. Thank you.